Good afternoon, everyone, and thank you for joining the Spring 2021 Collaborative Seminar Series hosted by the Center of Geriatric Nursing Excellence in collaboration with the Center for Nursing Research at Penn State College of Nursing. My name is Janice Whitaker, and it is my pleasure and privilege to serve as the CGNE Administrator and Community Liaison. Today's seminar is entitled Trends in Racism and Health Inequities Among Aging Populations of Color. It will feature a keynote by Dr. Sheldon Fields, followed by additional gerontological perspectives from Drs. Donna Fick and Marie Boltz. Before we begin, we do have a few announcements. This seminar is being recorded. Questions and comments may be entered into the Q&A, Zoom Q&A, which can be found at the bottom portion of your screen. The post-event evaluation survey will display in your browser following the seminar and will be emailed to you in one day. You can take it at either time. Please complete it at least within a week in order to earn continuing education units. While the post-event survey is required to earn CEUs for registered nurses, we do encourage that all attendees complete the survey as well to help collect much of the needed data as part of the Age-Friendly Care PA initiative. Continuing nursing education certificates will be emailed to participants meeting all requirements within 1 month following the seminar. And if you have any questions or have any particular comments or feedback for us, please feel free to email us at cgne@psu.edu. Now it is my pleasure to pass the microphone to one of our CGNE affiliated students, Emily Bratley Whitaker, who will be introducing our speakers.
Thank you, Janice. It is my pleasure to introduce our speakers today. Our keynote speaker is Dr. Sheldon Fields. Dr. Fields is a research professor and associate dean for equity and inclusion at the Pennsylvania State University College of Nursing. He is a well-known and respected HIV/AIDS prevention research scientist with a focus on young men of color. He is the first male registered nurse selected for the Robert Wood Johnson Foundation Healthy Policy Fellowship Program, a fellow of the American Academy of Nursing, Association of Nurse Practitioners, and the National Academies of Practice, and a lifetime member of the National Black Nurses Association, currently serving as the organization's first vice president. Fields is also founder and CEO of the SDF Group, LLC, which is a health innovation consultant company. He has 29 years of experience in the health sector as an educator, researcher, clinician, administrator, consultant, health policy specialist, and entrepreneur/business owner. Our panelists, Dr. Donna Fick and Dr. Marie Boltz, are returning speakers, so I will introduce them briefly. Dr. Fick's research and practice has focused on two critical issues in older adults: inappropriate medication use and delirium superimposed on dementia. Fick also serves as a faculty and advisory member on the national movement Creating an Age-Friendly Health System initiative with the John A. Hartford Foundation and the IHI. She is a board-certified gerontological clinical nurse specialist. Dr. Boltz is a geriatric nurse practitioner with extensive cross-setting clinical and administrative experience. Boltz's areas of research include cross-setting interventions to promote functional health in older adults, the efficacy of informal and formal carers, and translational dementia research funded by NIH and multiple foundations. She is a fellow in the American Academy of Nursing and the Gerontological Society of America. Thank you for joining us today.
Okay, Well, good afternoon, everyone. And I first want to thank the Center and CNR for the opportunity to talk with you today and to bring forth a conversation about the trends in racism and health inequities among populations of color. When it comes to aging, the overall population, as you know, in the United States is becoming increasingly more racially as well as ethnically diverse, while aging at the same time. Adults, age 85 years and older, sometimes referred to as the oldest old, is the fastest growing age group in the United States. The number of those age 85 and older is expected to nearly triple from 4.1 million in 2016 to around 19 million in 2060. Those turning age 65 and over by 2040, that population alone will double to almost 80 million. Issues, however, related to healthcare disparities and inequities among racial ethnic populations persist, and some actually even worsen as the population ages, resulting in health vulnerabilities of a population that is disproportionately impacted by age in certain chronic diseases. We see here on the various slides just some background information and trends about this one, about the ethnic minority elder population in particular. And you can see that from 2017, by the time we get all the way out to 2060, the population of those who are older and ethnically and minority diverse will continue to increase. We will become a majority minority nation. So we can't begin a conversation without having some discussions about some common meaning. So when I talk about race, talk about any of the groups of humans that we divide based on physical traits regarded as common among people of shared ancestry. It is also a very social and political concept, not necessarily a scientific one. And ultimately, people are who they say they are, and people are how they self-identify. Racism, however, is really a belief that race as a fundamental determinant of human traits and capacities, and that racial differences produce inherent superiority of a particular race over another race. The concept of prejudice is really an irrational attitude, hostile at times, directed towards individuals or groups or race for their supported characteristics or supposed characteristics. White supremacy is really the belief that the white race is inherently superior to other races and that white people should be in control over all the other races. So, to begin to discuss trends in racism in America, you have to look at the long historical line of discrimination and oppression against people of color, especially African Americans and Native American indigenous populations, dating way back 400 years to 1619, when the first enslaved Africans arrived in the Virginia colony. The painful history of slavery in America has never truly been dealt with or reconciled, and it has been followed by the period of racial segregation, where separate was never equal, not even with the landmark Supreme Court decision in Brown versus the Board of Education in 1954. The period from 1954 to 1968 saw the fight for civil rights in the United States, which was a decades-long struggle by African Americans and their like-minded allies to end the institutionalized racial discrimination, disenfranchisement, and racial segregation in the United States. This period ended in 1968 with the death of Martin Luther King Jr. The period of 1970 to 2000 saw a mix of accomplishments and setbacks for people of color in the United States, ultimately with growing economic inequities, with white families doing much better than Black and Brown families as a result of institutional racist practices. The country, however, took a huge, hopeful step forward in 2008 with the election of Barack Obama as our first Black president. But his historic presidency was marked with partisan political fighting and was followed by the racial divisive presidency of the 45th president of the United States that just ended yesterday. The trend in current day racism was punctuated on May 25th, 2020, when the world watched a white Minneapolis police officer hold his knee on the neck of George Floyd, a 46-year-old Black man, for 8 minutes and 46 seconds, resulting in Floyd's death. This sparked international outrage and protests. Here in the United States last summer, we saw social upheaval highlighted not only the death of George Floyd, but the hundreds of killings and shootings of Black and brown people at the hands of law enforcement officers. These shootings and killings date back many years and gave rise to the Black Lives Matter movement that has really taken hold and seeks to bring awareness to these issues. The slide on your right has a few pictures of the many victims who have been killed, such as Breonna Taylor, Rashad Brooks, Trayvon Martin, Tamir Rice, Eric Gardner, Philandro Castile, Jordan Davis, Sandra Bland, Oscar Grant, Kayla Moore. And in keeping with the ancestral ways, we simply call their names. We call their names. The pandemic of racism, now being acknowledged, was only made worse by the additional insult of the COVID-19 pandemic, which I will discuss later in this presentation as an example of the trends in healthcare disparities among older populations of color. But I cannot begin and move forward in a discussion about trends in racism without discussing the recent events in our history. Here on this slide is a depiction of what happened in our nation's capital on the 6th of this year, when we witnessed an insurrection and seditious acts by others emboldened by the current past administration with a course of divisive racism. It was also shown the differences between which those who protested on that day, in the slide at the bottom, and those who protested in peaceful Black Lives Matter. And the comments in social media was, had most of the participants been Black, our nation's capital would have looked very different. But yesterday we turned the corner in the inauguration of our 46th president, President Biden, and the nation's first female president, first vice president, first female Black vice president, first Indian American vice president, Kamala Harris. The end of the slide here in your bottom is the solemn, peaceful dedication and acknowledgement of those who have suffered and died due to COVID-19. The slide simply says and reminds us, this is America, this is also us. When it comes to forms of racism, I want to be really clear about the difference between structural racism and just quickly institutional racism. So when I talk about structural racism, I'm really talking about those systems in which public policies and institutional practices, cultural representations, and other norms often reinforce ways that perpetuate racial inequity. You know, it really talk about the dimensions that really happen that allow privileges, mainly associated with whiteness, that disadvantage associated characteristics associated with people of color that have endured and adapted over time. When we talk about institutional racism, it refers to policies and practices across and within institutions that intentionally or not produce outcomes that chronically favor or put one racial group at a disadvantage. The often exemplars of this is the racial differences seen in outcomes of our criminal justice system, our school systems, and employment discrimination. When we talk about how racism then gets expressed, we talk about a cultural dominant culture being imposed in terms of white beauty standards and white collar crime being normalized. We talk about institutional, that sets up, again, the advantages of white people versus other people in things like education, housing, and jobs. Then it gets down to the personal level and how people put themselves in places to be superior over their colleagues, acts of implicit bias, and acts of microaggression. So healthcare disparities defined by the World Health Organizations are those differences in health outcomes that are closely linked with social, economic, and environmental disadvantages, often driven by social conditions in which individuals live, learn, work, play, I always add die as well. This definition of healthcare disparities is one that that resonates most with me. And the comment at the bottom, when white folks catch a cold, Black folks get pneumonia, we basically means that any healthcare issue in the United States that befalls the population is oftentimes worse in Brown and Black communities. And we saw that recently with COVID-19. So what about trends in health over the age of 65? So just that we're clear, here's some common chronic conditions for those who are age 65 and over. The incidence and prevalence of chronic health conditions, increases with age. However, the incidence of those chronic conditions in aging populations of color are oftentimes points to glaring disparities. So what are some of the trends we can point to and see how racism factors into how the chronic conditions come out to be more disparate in certain populations than others? And then what can we do to address and reverse some of these trends? So I'm just going to give a few exemplars. So when it comes to the issue of breast cancer or, cancer, cancers in general, the ones that are most common in elder populations are breast cancer, prostate cancer, lung cancer, and bowel. However, with the issue of breast cancer, despite improvements in early detection and treatment for breast cancer, Black women continue to have highest breast cancer mortality rates, simply meaning they often die more of breast cancer while not necessarily even having the highest incidence. So recent trends point to the incidence increasing among Black women, particularly aged 60 through 79. When it comes to prostate cancer, among US men, prostate cancer, of course, is the second leading cause of cancer-related death. But trends for 5-year survival for all stages combined was higher for white men than for Black or Hispanic men. Although survival by age varied by stage, survival was also lowest for those over the age of 75. When it comes to disparities in HIV, in 2018, overall, some half of people currently diagnosed with HIV were over the age of 50. Most of those age 50 diagnosed were men. Trends from 2014 to 2018 showed that HIV diagnoses actually decreased 6% in people over the age of 50. However, compared to all people with HIV, people aged 55 and older was shown to have higher viral suppression rates, which means that they actually do better when they take their medication. Now, there's an overall racial disparity in HIV because African Americans make up only 13% of the population, but they represent over half of all new cases. And this actually is a trend that continues as the population ages. Racial trends in diabetes diagnosis shows higher rates among ethnic minorities, shown here on your screen. I'm not going to read them to you, but simply to say that the higher rates are seen in Brown and Black communities as people age. Here's just a startling statistic about diabetes and health disparities in the Hispanic population, noting that Hispanic adults are 58% more likely to suffer from diabetes, yet less likely to be diagnosed compared to the total US population. And the percentage of Americans age 65 and older with diabetes continues to be high. When it comes to trends in Alzheimer's and dementia, which my colleagues are far more experienced and will talk to, but we actually see that when it comes to race and dementia, the risk of which is higher in Black and Native American and Latino populations compared to whites, which is you see on the slide. In the estimates of Americans with Alzheimer's disease, you see the overall incidence is expected to increase over time. And currently, compared to the white population, we're seeing higher rates of Alzheimer's among African American and Hispanic populations. So, in terms of a summary slide about trends, you see that African Americans are more likely to die at early ages from lots of chronic diseases, whether it be high blood pressure or stroke, and you can see those 50 to 64 and the differences between the white population and the Black population. When it comes to trends again, and sort of just hypertension, the global burden for hypertension, of course, increases as the population ages. And it's primarily due to increase in obesity and things that affect the world's population. Overall, the prevalence, though, of hypertension increases with age for those 60 and over, accounting for most cases. And here on this slide, simply down here at the bottom, you'll see the difference in the increase between African Americans and whites, not so much differences between the Hispanic population. When it comes to LGBT healthcare disparities in older LGBT adults, well, one, the LGBT older adult population is growing. And it's a hard estimate because people don't always identify. However, in general, with health trends for older gay men, you see higher rates of smoking and recreational drug use from the time that they were younger. You see higher incidences of things like anal cancer, and issues related to prostate cancer, and an increased higher incidence of HIV and other STIs. With older lesbian populations, you see more smoking and obesity, which increases their cardiovascular risk. You see that they don't always get the best cancer, cervical cancer screening. And 29% of lesbians do not have a routine PAP at all. And you also see a greater incidence of breast cancer amongst this group. So, COVID-19 and its health disparities, we saw that the rate of Black fatalities was more than 2 times that of whites with COVID-19. In many of the states listed here, and that ratio jumped to 5 to 7 times. And we saw those disparities very early in the COVID-19 pandemic. So a lot of times people were asking, well, why is there differences? Why did we see that? So generally speaking, an overrepresentation of Blacks in the essential healthcare workforce, in population density, people living in close proximities, intergenerational households, which are quite common in ethnic minority households, historical trauma and mistrust of our medical system, structural racism and cultural incompetence in our healthcare system, lower rates of health insurance, lack of Medicaid expansion in the southern states with large Black and other brown populations, and a difference in social determinants of health, which I'm going to talk to in a moment. And again, higher incidence of underlying chronic health conditions, which we've already discussed. But this slide just even hones in on the fact that 8 out of 10 COVID-19 deaths reported in the United States had been in adults 65 years and older. And we saw that very early on through multiple reports across multiple states when it came to the incidence of COVID-19. But not only was it more prominent in older populations, it was also more prominent in older Black and brown populations. So ultimately, we want to get to having a sense of health equity. And Dr. Camara Jones, former president of the American Public Health Association, defines health equity as the assurance of the conditions for optimal health for all people. She further goes on to state that we cannot have health equity without 3 principles to achieve it: providing resources according to need, valuing all individuals and populations equally, and recognizing and rectifying historical injustices. So the differences in health disparities has been long known in this country. The Institute of Medicine's now the National Academy of Medicine's historical study about unequal treatment showed that minorities received a lower quality of healthcare than whites, even when they had the same health insurance or ability to pay. And the causes of this was pointed out as our healthcare system and organization operations, the cost, public health insurance access, the patient's attitudes and behaviors, historical mistrust by brown and Black communities as a result of the historical medical mistreatment that they've received in our healthcare system also plays into this. And of course, there is healthcare provider bias, prejudice, and uncertainty when treating minority populations. Lots of isms and stereotypes and a lack of communication, which manifests itself in implicit bias and attitudes, which are automatically triggered, not at one person's conscious level, explicit bias, when a person may actually be aware, however, their belief in their value systems forbid them from correcting their bias towards any particular group. So what do we see in terms of the social determinants of health? And I really like this slide by the Kaiser Foundation. It speaks to the social determinants of health across several spheres. In terms of economics, again, historical lack of employment, discrimination, income inequality, expenses. When it comes to your built environment, the state of housing in ghetto and other communities in which these populations live, the lack of transportation, parks for recreation. There is nothing more that determines the outcome of your health more in the United States than your zip code. Even access to quality foods and things like food deserts really all speak to the health outcomes that we see at the bottom of the slide, with increased mortality and morbidity, decreased life expectancy among minority populations that doesn't change as these populations age. We see a growing wealth inequality in general, where the wealth of white families is so much more than brown and Black families. And on this slide, you also see the percentage of seniors living at or below 100% of poverty by race. And you can see the differences in Black, Hispanic, and even Asian communities compared to white communities. So how do we take on the trends and what do? We really have to encourage that those who are coming to well visits are screened, do a social determinants of health screening to really see where the populations are. Support community-based programs that seek to address multiple social determinants. Programs must be focused on low-income elders, which are oftentimes disproportionately also brown and Black. We have to integrate and streamline benefit enrollment and provision, encourage the development of affordable senior housing, plan for transportation needs of our older populations, ensure the integrity of our Social Security safety net, which oftentimes is the only income that brown and Black populations as they age have access to. Lastly, we need to increase the diversity and cultural competence of the elder healthcare workforce, and that includes nurses, because nursing, while the largest of the healthcare professions, is still not diverse enough to meet the needs of our growing and diverse older aging population. My final thoughts. And, ultimately, we really want to we're not really talking about equality. Equity partly gets us there, but full liberation in which everyone has access to those things to improve their life really should be what we're striving for. I'll end with one of the quotes on here. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane, as stated by Dr. Martin Luther King Jr. I'll end there and I'll turn it over to my colleagues to continue.
You're on mute, Donna.
Thank you. That's going to be the word of the pandemic. You're on mute. Thank you, Dr. Fields. And before I pull my slides up, I want to welcome you to our center. I hope this isn't the last time we see you at one of our seminars. And I feel like, I know you're still new, but I feel lucky because we were able to have some sessions this past fall. So I also feel like you're part of us. So thank you so much for.
Absolutely, my absolute pleasure.
We are very lucky to have you. So thank you. Let me just pull up my. If you can't see them, someone will text me. So I'm just going to take a couple of minutes really to talk a little bit about the intersection of ageism and racism and to reflect on what Dr. Fields has presented to us and to raise some questions for our discussion in a few minutes. Part of my development in the intersection of ageism and racism is to realize I'm not an expert and I am learning. I think I mentioned just a minute ago that this fall I was part of a book discussion with Dr. Fields, which I hope we have some more of these. We're reading about how not to be an anti-racist. But I have been thinking about, so what I'll say about that is the biggest thing I've learned from that was don't let that be a barrier for you to identify and eliminate racism and health inequities in your everyday life. Don't let that be a barrier for self-reflection and learning more, because I think for many that can be a barrier. But I have been thinking about the concept of ageism for a long time. This is a paper that I wrote, an editorial that I actually wrote on a plane. And I say to people that want to write, is like, it's the most powerful things that you write are things that are bothering you. And this was the issue of ageism and disableism bothered me a lot. So I began to write about it and think about it, even though it's not my primary area of research. But in doing that, and in what we've experienced in the last year, I also realized that there's a lot that I still need to learn. And then the other thing I'll say in my couple of minutes is that ageism and ageism, just like racism, really does impact care. In the intersection of ageism and racism, as Dr. Fields just showed us, impacts care greatly. This was a 2020 systematic review by Chang and colleagues that was recently published. And it showed again that ageism in our writings, in our care, actually results in worse outcomes. When we look again at the intersection of ageism and racism, we see this again. And I want to point out a couple of things about this slide. Again, this is the Kaiser Family Foundation that has some excellent data. And they looked at 13,892 nursing homes, so over 90% of the nursing homes. And they looked, something that's interesting about this is when they first began to look and say, okay, well, which facilities actually report deaths by race and ethnicity? Only 4 states did this. Only 4 states reported this: Iowa, Indiana, Louisiana, and Mississippi. And so one of the things I'll say here as a researcher, and I'm going to quote Kedar Mate, who's the president of the IHI, and addressing health inequities and racism is the #1 priority of the Institute for Healthcare Improvement for this year, in that we must identify and eliminate racism, and I'll add racism, ageism, and healthcare disparities and health inequities. But in order to do that, we must measure them and we must understand them. And so I think as a researcher, that's something that I've found very striking. But in this, one of the things we know, so we already know that 80% of the deaths from COVID-19 were older adults. In nursing homes, about 40% of those were attributed to deaths. But the other thing we know is that in those, so persons of color, African Americans, Hispanics actually make up a smaller percentage of those in nursing homes. But in those nursing homes that had a higher percentage of Blacks and Hispanics, they had a 63% higher death rate compared to those that had fewer percentages of Blacks and Hispanics. So again, we need, in order to understand how we can eliminate ageism and racism in the intersection, we need to measure. I'll also just leave you with a couple of resources and then questions for our discussion later. Frameworks Institute is an important resource. They have a lot of work. They have slides and resources that you can use, to think about how to address negative attitudes towards aging. They actually do research on what are the best ways to shift the thinking about aging in older people. And, I think I did this for earlier talks. I won't repeat it here, but we all know, how many times, if you could raise your hand, I know they would all go up. How many times during COVID-19 did you be in a conversation with someone or see on social media, will people say, it's only old people that are dying of COVID-19. I don't need to wear a mask because it's only people with disabilities that are dying of COVID-19. And so it was people with disabilities, older people, and people of color that were dying of COVID-19. And that's an important point to remember. So again, and one of the things they say in Reframing Aging is to talk about successful aging. Words are powerful. There are several publications that I'll refer you to later where you can think about changing the way we talk about older adults and changing the way we talk about race and aging that are helpful. Again, this is just more from the Frameworks Institute, talking about how we can talk about this and keeping focus on the society's responsibility to treat older adults as equal, avoid slipping into this idea of compassion or mercy or right to dignity, because then that shifts it to, and I believe this is similar in ageism, but Dr. Fields can talk with us more about that, but it shifts it to this paternalistic or the notion of older people as others. And I think that's a really important and critical point we can talk more about. So I'll leave you with some readings and self-reflection. Down below is 80 above 80. And I will say that I looked at that list because I thought it was cool, but there are some problems with that list because it's a lot of, there tends to be a predominance of white older men in that list, but also thinking about the idea of older adults. The time is always right to do what is right. This is an editorial that we had hoped to come out for the inauguration day yesterday, but this will be free on the Journal of Gerontological Nursing website. And I think it'll be up there in 3 to 4 days, I hope. But I hope that you visit our site and pull that down and read it, because it gives you some readings and it talks about the use of self-reflection for older adults in addressing ageism and racism. It talks about communication and advocacy and policy and really what we can do as gerontological nursing colleagues and as clinicians to address this issue. And then at 4 p.m. today, Dr. Fields mentioned this, but the National Academy of Medicine in 2003 put out an important report about health inequities. And today at 4 o'clock online, they'll releasing another report. In this report that will be published February 1st in Health Affairs addresses racial and health inequities and how we go forward. Particularly, they actually have recommendations for the next administration. At the same time, at 4 o'clock today, I am actually part of this. I'm a co-author on the second one, and this is called Actualizing Better Health and Healthcare for Older Adults. And we talk about the digital divide, nursing home reform, and we talk about health inequities in older adults. So I encourage you again to look for those later today. These are just some more references that we will make sure that you have in your hands. I believe that many of these will be very helpful to you. Several of them have direct links. And then I'm going to leave you with just a couple of questions before we move on to Dr. Boltz for you to think about. And these are some of these are things that popped in my head when Dr. Fields was talking, is that when we talk about the social conditions of a nursing home, right? Because there's a lot of talk right now in the aging field about how do we transform nursing home care and the care of older adults who had disproportionate deaths during COVID-19. How do we address racial inequities as we address nursing home reform? How does the divisive racism that Dr. Fields mentioned impact how we change our care for older adults and older adults of color? And then lastly, how can or will you apply what Dr. Fields discussed today to the care of older adults in your practice, your research, and your teaching? And we'll stop sharing here and turn it over to Dr. Volz.
Hi, everybody. I really want to add my thanks to Dr. Fields for that tremendous presentation and sharing, and also welcome you to our center activities and tell you how thrilled we are that you're working with us. You know, I'm beginning to learn more and more, and I hope to continue to learn. So when I heard about this presentation today from Dr. Fields, it really triggered my thinking around my dementia research. And what I began to think about was how having dementia really adds another layer to the person who is living with dementia, who's also experiencing racism and ageism. So they're sort of confronted with a triple threat to their health and predisposes them to even more health disparities. And, you know, people with dementia, those of you who are caring for a loved one with dementia or who are working with people with dementia, really tell us over and over again that they feel like they're rejected by society, that they're rejected by their family members. They feel shame and they feel isolated, and they really feel like they're no longer a part of things. And in some ways, their personhood is very much diminished. And that itself contributes to isolation and psychological morbidities and even physical challenges and health problems. And equally important, this stigma leads to delaying getting health treatment and getting the diagnosis. And we know that African Americans who are experiencing signs of dementia are less likely to engage with a healthcare provider and get the diagnosis. There's a testing of friendships, family relationships change. People begin to react and interact with the person with dementia in a different way, as if the person that was here, you know, 10 days before the diagnosis no longer exists, and this is now a new person. And a lot of that, we know, is due to ageism, as Don has talked about, and ignorance and fear, but also language plays a key role, as Donna has said. You know, when we talk about dementia, we talk about the war on Alzheimer's disease, and it's an epidemic. We also talk about Alzheimerization as the reason why there's support for euthanasia. So often there's a linkage between euthanasia and the Alzheimer's diagnosis. And also there's negative terminology. Instead of saying that the person with dementia is walking to find something or walking about or looking for something, we use terms such as wandering, and pejorative terms when people are upset. We describe people who are upset as agitated. And one of the final reasons that I think is important to consider is that the person with dementia is often defined by how well they can think. So we defined people in relation to their cognitive function. They think, therefore I am. So in my work with people with dementia, I really have been trying to think of how I support their personhood and help to support interventions and care practices that really help the person continue to be who they want to be and live their life the way they want to be, live it, and also, you know, have an image of self that is really consistent with who they believe they are. And one of the tools that I think is helpful is on the Alzheimer's website, which really helps the person who is newly diagnosed with dementia sort of put a stake in the ground and identify themselves as being more than the disease. And it really helps walk them through defining who they are more than their diagnosis. So they describe their profession, their relationship with others, their talents and habits, and personality traits. Now, one of the things that I've been really concerned about with working with people with dementia and racial disparities is that I have found that often we sort of miss the mark, or I'm missing the mark, most certainly, in terms of, what I've considered in terms of my workforce. Dr. Fields mentioned how it's really important to consider diversity in our workforce. He also mentioned the importance of meaningful measures. And he also challenged us to think of how income inequality really affects how we're trying to promote healthy behavior and general health for the person living with dementia. So I've tried to consider that, and I welcome thoughts from people who are on the Zoom today. We've tried in our research to really make sure that we have a diverse group of resident or research assistants. Our research assistants and nurse interventionists represent the population that we're working with. And also I've learned that, our measures aren't hitting the mark in many ways. And we spent some time after our intervention, which is really focused on helping family members promote functional recovery and cognitive recovery post-hospitalization. We've asked family members to tell us, what do you think of this burden scale? And they say to us, why are you using the term burden? That is really an offensive term. I love my grandmother, and you shouldn't be calling this a burden. And what do you mean by strain? So we're really trying to consider how to create better and more relevant measurement. I also have learned that I have made some mistakes or maybe been short-sighted is probably a better word in terms of my interventions. And so when we're interviewing family members, they tell us, yes, that teaching was good, when we're making sure that we have a scheduled plan every day to make sure the person is, up and about, and we provide this type of activity and all. But it's hard for me to focus on that because I'm worried about blank, 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 blank. And one of the things is that I've been really conscious of is that I need to be more worried about issues such as heating and food insecurity. And I would really emphasize food insecurity as a big issue. And so I'm trying to be more thoughtful about that. And I'd like to hear about others' experiences around that. These are two, I think, really good websites that I've been trying to educate myself around these issues, which talk about the demographics, some of which Dr. Fields has described, and also some of the advocacy work that's been done on behalf of African Americans who are experiencing dementia. One of the things that is really important to understand is that African American individuals with dementia, just with dementia, have higher rates of hospitalization, more frequent hospitalization, greater acuity, longer length of stays, and higher readmission rates. And so we have to consider, what is that? We found in our work, or what are the reasons for that? We found in our work that there were some disparities in terms of symptoms. So we're beginning to look at the symptom burden of people with dementia when they're acutely ill. And we found that our patients admitted to the hospital had more depression. They also had more functional loss, and also were less likely to go back to their pre-admission functional status. There's lots of things to consider from a research perspective, theoretical considerations, what is the cumulative effect of these disadvantages? And so looking at theories such as cumulative disadvantage and life course theories, it's not enough that we identify that there's disparities. We need to look deeper at addressing some of the reasons for these disparities. And also consider how our interventions can be informed better. So informed better by qualitative research and exploring with people, that is patients as well as family caregivers, what do they need, what do they want? And also trying to build into our research designs adaptations and being flexible and nimble and interventional designs that are adaptive in nature and can stop at some point, evaluate the outcomes, and maybe try a different intervention. I provided some references and resources, but they're really just basically some thoughts that I had, and I'd really like to hear what other people are thinking.
Okay, now that our presentations are complete, we have just a few minutes for some comments and some questions. If you could put any comments or questions you have for our presenters in the Q&A feature that's at the bottom of your screen, that would be great.
So Janice, while we're waiting for questions and answers, I really want to make one point about the issue of race and racism, which, you know, this country is really still reckoning with how to deal with the pandemic of racism. And we saw yesterday, as an example, in the very first hours of the new Biden administration, with executive orders, the creation of a whole government initiative to advance racial equity that addresses equity for all, rescinding an executive order that eliminated diversity and inclusion training for government agencies and federal contractors, reversing a lot of the executive orders of the past administration that dealt with undocumented immigrants and reassured that those in the DACA program could stay, lifting of the quote unquote Muslim ban. So I always say to people, if you're not having conversations about race and racism that are making you uncomfortable, you're probably not having the right conversations, because this isn't easy for anyone, but it is something that we must do. And as I think about the elders, even in my own family, who I watched in sort of awe over the last couple of years, as you know, they lived through you know, the civil rights movement. You know, I'm a child of the post-civil rights movement. I didn't really have that experience, but I really did have an experience over the last couple of years in which, you know, race and racism has played out in so many painful ways. But when I think about, you know, how those elders who lived through it were re-traumatized by what they were doing. And we don't talk enough about the traumatization that feeds in to a lot of growing health inequities.
Yeah, thank you for sharing those comments. And I appreciate the fact that you use the word uncomfortable, you know, that, and when Donna spoke as well, she's one thing that struck me was not letting our individual lack of expertise or insight on this topic to be a barrier, you know, to self-improvement, that we all can learn, we all can grow, we all can explore, but it is uncomfortable at times. So, and I also appreciated when Marie shared that there have been times she has, I think she initially said the word mistakes, but then kind of rephrased that. But I think, you know, in terms of research techniques and methodology and considering different aspects of her work, you know, taking into consideration. So it's my hope that these three fabulous presentations today are just the beginning of an opportunity for us to have a conversation, to continue conversations, to continue our learning, and to improve our work in this area. So
There is a question in the Q&A that I think we should address. It's to Dr. Fields.
I'm
And
not seeing it, Donna, so if you see
do
it.
you want me to, I'll do it, but it's to Dr. Fields. I had some thoughts about it. I'm sure you'll have some thoughts too. Dr. Fields, one aspect you did not discuss was the trend for many individuals not following doctor's orders. Any suggestions to improve compliance?
So interestingly enough, I used to go to the doctor with my grandmother who raised me, right? Or better yet, she would come from the doctor and call me to have me explain things to her. And I would say to her, didn't you just leave your doctor? She would say, oh, yes. I'd be like, well, why do you ask him these questions or her these questions? Well, they were busy. Or, I didn't know if I was asking the right question. So I really want to caution us when we talk about patients' non-compliance. A relationship with one's healthcare provider is just that, a relationship. And it is a give and take relationship. If you have populations of brown and Black people who, for some very real reasons, do not have trust in the healthcare system, they're not going to necessarily take at their word what their provider is actually saying to them. That is why we need to increase the percentage of medical providers or healthcare providers of color within our system. The research is replete that older individuals, brown and Black individuals, do better and have an increased, quote unquote, compliance, if you will use that word. I don't like that word. When they're dealing with healthcare providers that mirror them or reflect their historical sort of presence. So, I'll stick to nursing for just one moment. Nursing is still overwhelmingly a white profession. And we do not do enough in our profession to increase our numbers. And we are the largest, so we have a larger touch, but there's not an easy answer to that. But I do know that one of the solutions is we need to increase the percentage of people in that population that look like them.
And I think we have time for one. Oh, I'm sorry, Marie, did you also want to react to that question?
I was also wondering, Sheldon, if sometimes you found that in addition to what you've suggested, there's also a tendency where we come up with interventions or things that people should do without recognizing or exploring with them all the barriers they have to doing them. Do they actually have the resources to do what we want them to do? Or do they have the time, if they're caring for multiple other family members, to take care of their own health? I mean, sometimes there's, we just blindly prescribe.
Well, there's a statement that goes, nothing for us, by us, without us. And I'm amazed at the number of researchers that develop things that they truly think are helpful, and they never went to the community and did the ground level up work of asking the community what they actually think would be helpful.
So we have a couple questions in the chat, and we only have a couple minutes left. One is from Ann Kolonowski. What are some suggestions for improving the recruitment of people of color into research studies so that we can learn more about their healthcare needs and appropriate ways of intervening to reduce health disparities?
Acknowledge their trauma, their historical trauma, and increase and give access to PIs of color who actually can partner and bring a genuineness to the work and a level of trust that does not exist in some of these communities.
And Megan McGraw is asking, is there any research that you are aware of that examines nursing and/or medical students' understandings of health inequities and disparities exiting school? Also, is this addressed in the current curriculum in nursing school? So we have just about 30 seconds to respond to that, and then we're
going to respond to that one, Donna? Go ahead.
Yeah, it's a big.
Yeah, I think you can. I will say it's improving. Having been in a college of medicine, a lot of people are using the social determinants of health framework. But I think as Sheldon, I'll let you do in terms of racism. I think we have a long way to go. I think there's a lot of discomfort. We don't necessarily have the expertise. And so that's the other thing, we need to bring the expertise in. But I do think we're improving a little bit in terms of the social. I believe that's in a lot of curriculums, but
Yes.
go
Well,
ahead.
the social determinants of health is one thing. We need to do a better job. Even I'll give you a really good example very quick. When you look at how we teach the history of nursing to nursing students, it is a very white Eurocentric perspective that begins and stops with Florence Nightingale. And therein lies part of the problem, because it doesn't acknowledge the luminaries and other people of color that have contributed to the nursing profession. And people have no exemplar about people who look like them because we don't teach it. And it's very one-sided.
It's an excellent point.
Mhm.
And I'm afraid we have to end there. Thank you so much for this amazing session. The presentations were fabulous, such great information and insights and resources. So hopefully that will help us continue to reflect and learn moving forward. And hopefully we can revisit this together again sometime soon. So thanks again, everyone. And to our participants, please complete the evaluation tool. It will pop up in your browser when we end the session, and it will be emailed to you tomorrow. So thank you very much for joining us today.